we're just about set. Okay, whenever you're ready, take it away.
Okay, so for the first question, just describe who you are, state your name, what you do here, what your position, what your title is, and what your work is.
My name is Kiran Moy Das. I am a professor of medicine, chief of division of gastroenterology and hepatology, and also in the Department of Medicine, and I have a joint appointment with the molecular biology department at Rutgers University at the Robert Wood Johnson Medical School. I am an MD PhD, MD from India and PhD from Edinburgh, Scotland. So I have been working at the Robert Wood Johnson Medical School for last close to 30 years. In fact, the GI department at this medical school has been initiated by me when I first came here, and over the last 3 decades we have an excellent clinical program at all levels, postgraduate as well as undergraduate, and also a research laboratory as you see here. And this is the research focusing mainly on inflammatory bowel disease, popularly known as IBD in short, and which consists of 2 diseases, one ulcerative colitis, this other one is called Crohn's disease. Both are chronic intestinal inflammation, and this is approximately affect 1 million people in the country. So the research what I have been involved over the last, as I mentioned, more than 20 years in terms of the basic research part, is mainly pathogenesis or the cause of these disorders. This is a chronic disease, as I mentioned, so there are inflammatory process goes on in the intestine, and these patients, they go into remission, complete remission, normal quality of life, normal life with the medication, but sometimes they get into flare up and they get with the symptoms. So this disease process, understanding cause of the disease and how to treatment aspect, that's what is the subject of our study in this lab, which is the research component of Crohn's and Colitis Center of New Jersey. A few words regarding this center is a multidisciplinary program, clinical service and research what we are doing, and we follow at this center approximately 1500 patients with colitis and Crohn's disease, and through the clinical service as outpatient, which is downstairs, or some of the patients when need to be admitted, they are admitted at the Robert Wood Johnson University Hospital, which is the adjacent to this building. So both inpatient admission as well as outpatients are handled by us, and these multidisciplinary physicians and researcher involved Department of Medicine like myself, and the Department of Surgery, Department of Pathology, Radiology, and also Psychiatry, Department of Psychiatry. So it's a multidisciplinary. It has been designated as Center of Excellence by New Jersey State. So this is the clinical service which I provide for the school and also for the research. Many of these patients are also contribute to this process.
Great.
That was great.
Good, yeah. Is the how's the noise?
It's it's a little loud, but I can try to work with it. Let me try
We
to
can
work with it.
switch it up.
You can switch that up? Oh, okay. Here, let me grab this. Yeah, that'd be great if you don't mind. Just when it kicks on.
Yeah.
What's that?
Want to cut some questions. I just want to follow
Ask
it.
as many as you want.
Yeah.
No, it looks like that.
Okay.
No, that's fine.
No, it's thank you for trying.
Yeah.
No, what I can do, I can speak a little louder.
Yeah,
Yeah,
if you
You
can.
know, anything works. You can always cut it out.
Yeah, there's the power of editing is always.
There's a little bit less noise on the other side.
Okay. I think we should be okay.
You should be okay.
Yeah, I'm
That's
not,
fine.
not too
We'll leave
worried
it.
about it. Here, I'm just gonna
You
keep
have
this
the mic
mic.
and everything.
Mm-hmm.
Yeah, if any part needs editing, you can come back again.
Yeah, yeah, thanks. Yeah.
That's all right.
Yeah, we will definitely let you know.
Just
We'll
gonna put that wire underneath.
email Alicia.
Mhm. Yeah, no problem.
Just the position of the chair
Yeah, let's just move your chair.
over.
Just gonna move your chair a little bit over.
Oh, okay, no problem.
Great. Just 1 second.
That should be all right, Carlos. Leave it.
Great. Go ahead.
Okay, so can you explain IBD and its onset? All the different conditions.
Now, a few words regarding IBD. As I mentioned already, IBD stands for inflammatory bowel disease. Diseases. There are, as I mentioned, there are mainly two forms of these disorders. One broad group is ulcerative colitis. The other broad group is Crohn's disease. The ulcerative colitis is the chronic inflammation of the colon from rectum all the way up to the cecum, entire colon. It can affect the entire colon. And it's basically a chronic inflammatory process with the destruction of the epithelium of the lining of the colon and causing a significant amount of diarrhea, bleeding per rectum, and of course, as a secondary problem they face is that because of the chronic bleeding, anemia, weakness, lethargy, and in children, stunted growth. These disorders in approximately 20% of the patients can be in adolescent patients, young kids, affecting the teenage from our adolescent age and then continues throughout the life. As a matter of fact, the disease itself, interestingly, is found mainly in the second and third decades of life. As a result of that, these are all young people in their stage of learning and work life that can significantly compromised. Fortunately, the treatment is available. We can put them into remission and we can maintain the remission so that they can have the normal quality of life. Crohn's disease is also similar disease, but in the case of Crohn's disease, the disease can affect any part of the GI tract. As I mentioned, in colitis is the inflammation of colon. Itis means inflammation, so colon. So it's restricted to large intestine or colon. Whereas in Crohn's disease, it can affect from mouth to anus the entire part of the intestine, although commonly it affects the lower part of small intestine and the upper part of large intestine. And we call it ileocolitis because the small intestinal part which is involved is ileum. So that's why it's the inflammation of the ileum. And in children, sometimes the disease is diagnosed when they come with the history of the child is not growing or is not eating at a very young age. So one should always suspect the possibility of Crohn's disease in particular, where the retardation or growth restriction is a presenting feature sometime in young people. As I mentioned earlier, approximately 1 million people in this country, in the United States, are affected. At least 1 million, half and half, approximately half is ulcerative colitis, half is Crohn's disease. Approximately 4 to 8 per 100,000 population is the new incidence. So, whatever the numbers are there, is a chronic disease, as I mentioned, although we maintain the patients in remission, but to that is added this additional new diagnosis, 4 to 8 per 100,000 population. So, it is a fair number of this problem. It is not a rare disease anymore. Another interesting factor about that, this is more common among the white population, Caucasians, as opposed to African American, and certain population among the Jewish ethnic background, it is more common than the other Jewish population or other Caucasian. So, it is throughout the world it is, but some area there is a little bit more incidence is slightly higher. The other interesting thing of this problem is the genetic predisposition. Approximately 20% of the patients will give you a family history of another sibling, or the parents have the same problem, usually same problem. In other words, if it is colitis, the familial incidence of colitis is more common than the Crohn's, but both can happen, either of these disease can happen in the siblings or parents. So, first degree of relative can be also affected, and usually, as I said, up to 20% of the patients will have the positive history of a similar disease in the family. So, there is some genetic predisposition is there, although not 100%, and some of the genes have been identified which are looks like involved in this disease process. Approximately 15% of the genes has been identified, but still long way to go to understand the entire disease process. The treatment wise, there are all different kind of treatments are available, first step, second step, but more exciting development in treatment which are available now, which are known as biological treatment. And this is the exciting part, because with this biologic treatment we can induce the remission with almost 60 to 75% certainty. So, you can induce remission up to 70-75% of the patient, which is obviously a great news. And this treatment not only induce remission, can also maintain remission by giving the periodic treatment, and they are usually injection treatment, all these biologic treatment. Besides the injection treatment, there are a number of other tablet preparation, oral preparations, which are also very useful management of the patients with both colitis and Crohn's.
Let's see. So, with the onset of these conditions, on the phone I talked to you and you had described some stories that you'll hear from patients on how that onset happens when they get their first flare-up of these conditions. Can you describe that? And people, are they going to be able to live normal lives? You know?
Fortunately, with the availability of this new treatment and various types of treatment, we do manage to maintain induction of remission in approximately 80 to 90% of the patient. When I say induction of remission, is actually they get back the normal quality of life. So, majority of the patients we do succeed to achieve normal quality of life. Approximately 15-20% of the patients who has the most severe form of the disease, in them they significantly suffer. Their nutrition, maintenance of nutrition becomes a challenge, and as I mentioned earlier, it affects the young people in the second, third, maximum fourth, but usually the maximum is second, third decades of life. So that does compromise quality of life, particularly during the flare-up. But once the flare-up is controlled by the treatment, then they can get back to their normal quality of life. So about, as I said, approximately 20% of the patients need more close attention and sort of remembering taking the treatment properly. Many patients, once they feel better, but they are young people, so they forget to take the medications, they miss some of the treatment. Then that's the problem, that then they get flare up. So that is one thing the physician has to remind the patient that so that they continue the treatment. So I think besides that 15-20%, I said that most of the people with the type of treatment are available nowadays, that we can keep them under good control. But the important aspect is that, so you would like to go to a specialist, that person or the physician who has been dealing with these patients all the time, so therefore they can provide the efficient, appropriate care in these patients, because sometimes the disease also might be complicated with the for different complications, such as they can, because of the chronic disease, they can get intestinal obstruction, they can get perforation in the abdomen. So this kind of complications can happen sometimes, or fistulas communication from one part of the organ to the other. So those need more special attention, including surgical interference by the surgeons. So that's also very important thing to keep in mind.
And for the onset, what are those things that patients will tell you is
Yeah. The way this disease starts, as I mentioned earlier, is you get diarrhea and bleeding and pain abdomen. These are the three most important symptoms which bring the people to the physician's notice, that they will have, say they have diarrhea is not going away. Usually the common type of diarrhea caused by infection, they go away treated or untreated by 3, 4, 5 days. But this is because it's a chronic inflammation in the gut, in the intestine, they will have this diarrhea 6 to 8, 10, 12 times a day, usually with the blood, but sometimes blood in the stool they may not see, because it's a small quantity of blood it may not see, and they will describe as a significant amount of diarrhea, more frequently going to the bathroom, and presence of blood also should alert that there is something more serious as opposed to common type of diarrheal problem. So, and then along with some people in very acute case or serious case, they might have systemic symptoms such as fever, and then along with that the patient might get dehydrated. So fluid is very important at that stage of the treatment, and usually there is no specific test by which you can diagnose that you have colitis or Crohn's, other than history, taking the history. That chronic pain and chronic abdominal pain and diarrhea is the most important feature we look for. Then of course you do the investigation, besides the examination of the stool for any kind of infectious process, but you have to make sure that it is not infection, because the treatment what we provide for IBD completely different than what you treat the common diarrheal condition or infectious cause of diarrhea. So one has to rule out all those causes, and then you know that this is a chronic disorder due to IBD. The most important investigation is the colonoscopy. So this is a scope, or they visualize the colon. You pass the fiber optic instrument, which you pass through the rectum into the colon, and see the mucosa with your own, just like looking at any internal organs, and that will show you the evidence of inflammation of the part of the colon. Sometimes we go to the upper endoscopy in case of any upper GI symptoms like nausea. A lot of people have that problem also. Make sure that there is nothing else going on in the stomach, although this IBD usually in the small intestine and colon, as I mentioned, but sometimes it can also affect the stomach. So you might have to do upper endoscopy rather than colonoscopy. So that is also useful, because endoscopy is also useful because you can take biopsy, and sometimes biopsy is very important for accurate diagnosis of the problem. So that is also very useful.
And on the phone, you told me that the patients will say something caused their first flare-up. So there's a myth that stress causes the first flare-up, or steroids. Can you explain that?
And this is a common question we always face from the patients, saying that I'm taking the my normal food. I didn't take anything unusual. Still, I got the flare-up. Still, I started getting the symptom of this same pain, diarrhea, and presence and absence of bleeding. Both could be there. Some of the items which we have recognized that can cause flare-up or can bring the disease process back, and that is one of the most common things is the stress, acute stress situation. Stress does not cause this disease, but stress can influence the disease process, and this has to be acute stress. Stress, everybody has their stress in day-to-day life for various reasons, but it has to be acute stress, such as bereavement of somebody near and dear one, or I have seen number of patients during the divorce process. So that is also a significant amount of compromise of the quality of life at that time, those kind of things. So it has to be acute stress. The other thing also which can bring the flare-up, cause the flare-up, is an acute infection, like somebody having acute bronchitis or upper respiratory tract infection. So that kind of process also can causes flare-up. And among the medications which has been shown to be very important, and that's why we always tell our patients to avoid, is the NSAID group of drugs, non-steroidal anti-inflammatory drugs like ibuprofen, a common example. And as the ibuprofen is you can buy over the counter, so you don't need any prescription. So and if somebody takes, people who has colitis or Crohn's, and for any acute pain or strain in the muscles or joints, it's a common drug people use, but that drug unfortunately can cause a flare-up. So this is the other thing we always tell the patients right from the beginning while we are treating, that never take any NSAID group of drugs, but if you need something for pain, take the Tylenol, paracetamol. Paracetamol is no problem, you can take it, but NSAID group of drugs, aspirin or NSAID, those should be avoided.
Okay, that's good so far?
Yeah, it's great.
Okay. So we're just going to switch the path a little bit. Some of our project is focusing on the financials of patients. So, you hear financial specialists talking about things all the time, but a lot of the time people don't hear from a doctor's perspective about the financial aspect of these medical conditions. So one of our questions is that we're focusing on the Affordable Care Act, and we wanted to know, have you seen any changes in in the number of patients and all since 2010 when that act came out, and what's your views on the financial things of these conditions?
In terms of treatment of this patient, this is a challenge to the physicians taking care of the patient, and certainly challenge to our patients who have to pay to buy all these medicines. When the disease is mild, then the treatment we use are also relatively less number of medications we give, and they are relatively cheaper. In terms of biologic treatment, which I mentioned to you, that is the most exciting treatment point of view, but at the same time, unfortunately, all these biologic treatment very expensive. I face this challenge almost on a regular basis, because the biologic treatment are most of them injection, either intravenous or under the skin, and each of these treatment on an average cost approximately $1,500 to $2,000 for each treatment. So that is a significant amount of cost we are talking about, and depending on preparation, some of this treatment you have to take every 2 weeks or once a month. So which means you are talking about monthly expense of $4,000 or $5,000 for this treatment. In terms of tablet preparation, they are much less, cost is less, which is more manageable. And at the same time, very important thing we have to keep in mind that these are two chronic diseases. So they are chronic, which means you didn't cure them. And I do tell my patients that when at the first time when I see that I will not be able to cure your problem, but I would be able to, that I can guarantee up to 80–90% certainty that I will keep you symptom free and keep you normal quality of life. So the disease is there when we give all this treatment, but our objective at that time is to keep them under control so that they can continue their normal life. So therefore, they will need the medications. So they are obviously have to face this significant amount of cost depending on how severe is disease, what medicine they are taking. So that is true. So unfortunately, with the insurance changes happening all over, has been a significant challenge. There are quite a number of patients who, after a lot of effort, etc., when we induce remission in them, and then the medicine could not be continued, and they get a significant flare up again and come back. When I see that stage, who few months ago tell me that you saved my life, doc, you really saved my life, then I have to hear, no, I didn't save your life, you are back again because of the financial situation. That happens quite often, actually. I must say quite often. So what we have been managing thus far, we in fact yesterday I wrote a letter to the insurance company, to the drug company, to get the medicine free. So, but that's how many people, 1 or 2 people you can help as much as possible, some of the insurance company will not give whatever you write. So this is a challenge back and forth happening, and patients also put pressure. So the answering, in terms of how do you answer that? I think from various pressure from the patients and relatives and physicians, there are more this kind of program are available, provided by the companies, but nevertheless that is not sufficient. So hopefully some of the newer insurance and companies are also becoming aware of that. Of course they are aware, but how to reduce the price of these medications is a challenge for the pharmaceutical industry as well as for the whole field. So that is a challenge we have to face, and we have to struggle at this time and do the best whatever you can.
So if you can think back before 2010, when Affordable Care Act wasn't there, universal health care wasn't required.
Right.
What changes do you see from back then to now? Has it benefited the patients? What is your perspective on that as a doctor?
One of the things which I have been noticing over the course of last decades, last several years is that there are more and more number of people are not insured. Might be because of the geographical location, but besides that, I think in general the location in a same place. If you are all these years I have been practicing in this area, but my guess, I don't have the hard numbers, that there are more people who are uninsured or insufficiently insured to cover the whole expense are increasing. So unless this aspect is particularly health coverage is covered by some way, it is going to be more and more difficult for treating a disease like that, where the treatment is very expensive. So unless there is a significant changes happen in the whole medical care for our people, and this is going to continue and it will go higher and higher. But I can say from my own experience of treating my patients, these numbers are increasing. We have facing more number of patients with insufficient care or no care at all, no health care, and some of them are getting the Medicaid. Medicaid does help significantly, but that's not sufficient, and not everybody qualify for Medicaid. So that's become the challenge for the patient. As for example, I believe if somebody, suppose you have a house, you will never get the Medicaid. I am told. I am not 100%, but if that's the case, somebody has a house, at least he or she has a shade on the head, but that is not sufficient to buy your food and on the top of it buy the medicine. So these are the challenges for all of us, and so we try to do as much as we can.
Great.
Yeah, that's like
Is that
what
everything you have?
Yeah, pretty much everything I had. Maybe we can think of anything.
That's
That's
some
a
good
lot of good stuff.
Yeah.
A lot of good information. In terms of B-roll,